Good morning, dear professors and colleagues. It's my pleasure to be here again with you. Today we will discuss a new imaging category, which is the VI-RADS, and how we do it. This is my acknowledgement for my dear younger colleague, Shohinda. I was her supervisor in her thesis, and all our cases were performed in Ain Shams University Hospital. We will talk about some introduction about the bladder cancer and the VI-RADS scoring and how we do it, and we will present some cases. Bladder cancer is the most common tumor of the urinary system, and it is 3 to 4 times more in men compared to the women. 90% of bladder tumors are TCC, and the TCC morphologically are divided into non-muscle invasive bladder cancer and muscle invasive bladder cancer. And this is the cornerstone for management of the patient, to identify muscle invasion from non-muscle invasive disease. The gold standard for diagnosis of this differentiation is by cystoscopy and biopsy for discriminating muscle invasive from non-muscle invasive bladder cancer. But nowadays, multiparametric MRI was implemented in the diagnosis and differentiation between these two entities. We aim for discriminating between T1 and T2 tumors, where T1 tumors are the non-muscle invasive bladder cancer, and the T2 tumors where there is the early muscle invasive disease. Let's see how the normal MRI for the urinary bladder wall appear in the imaging. This is the T2 weighted image. We can see the muscle layer as a low signal intensity, but we can't see the mucosa or submucosa because they are of high signal, and they are normally masked by the high signal of the urine on the T2 weighted image. So normally we don't see mucosa or submucosa on the T2 weighted image. On the diffusion weighted image, we see the muscle layer as an intermediate signal, but we can't see the mucosa or submucosa because they are dark, and they are merged with the dark signal of the urinary bladder on the diffusion. On the dynamic study, the urinary bladder wall normally enhance, where we can see the enhancement of the mucosa and the submucosa, but the muscle layer show delayed enhancement with no early enhancement. What we see in the early phases is just the mucosa and submucosa. So how we can see the urinary bladder masses? This is an example for urinary bladder huge mass. It can be an intermediate signal on T2 or dark signal, and on the diffusion it is restricted because most of the TCC tumors, including the bladder or the ureter, they are restricted due to high cellular packing, and they appear as hyper-enhancing masses after contrast injection. How the VI-RADS developed? What is the VI-RADS? It is a vesical imaging reporting and data system. It is a method for structured reporting to allow the multiparametric MRI in evaluation of suspected bladder cancer. It is a systemic approach by using diffusion and T2 as well as the DCE for characterization of urinary bladder mass to discriminate between muscle invasion and non-muscle invasive disease. And we use this VI-RADS not for discrimination between benign and malignant lesion. It is a method of staging rather than characterization of the masses. Let's see the VI-RADS. We use the T2 weighted image, diffusion, and DCE. And we give a score from 1 to 5 depending on the likelihood of the presence of muscle invasion. The VI-RADS 1, there is less likely muscle invasive disease, while VI-RADS 5 there is a high likelihood of muscle invasive disease. Let's see how we can assess this. Every parameter we use in the VI-RADS, we give it a score. So let's talk about the T2, and we call it the structural category. Structure category 1, where there is a lesion less than 10 millimeter, or it appears as a flat lesion like here. If we see such a small lesion on the T2, it takes a category 1. Category 2, where there is a papillary lesion and we can see a stalk, or we can see that the lesion is not a papillary lesion, but there is a hyper-intense submucosal part of the lesion separating it from the muscle. While category 3 is the lack of the presence of category 1 or 2. Category 4, where there is an intermediate risk for that the lesion is invading the muscle layer, as we can see here. But in category 5, there is a true extravesical component located at the perivesical region. As regards the GWI, we also classify these lesions from category 1 to 5, similar to the structural category on the T2. In 1 and 2, they are less likely for muscle invasion, while 3, there is lack of category 1 or 2, and 4, there is likelihood of muscle invasion, while 5, there is extravesical component. And for the DCE, we have a category called CE category, and also it is categorized from 1 to 5, depending on the presence of the enhancement of the mucosa and submucosa, and if we have interruption of this enhancement on the dynamic study, as we can see in these examples. At the end, we collected the scores of each category and put them in a final categorization from 1 to 5, depending on what we find on the multiple categories, including the GWI, CE, and the structural category. The muscle invasion, to sum up, is the presence of uninterrupted smooth muscle and the presence of uninterrupted submucosal enhancement. This is a T1 tumor or below. This is an example for non-muscle invasive bladder cancer, where we can see there is a tenting of the urinary bladder wall, and there is a pedicle for the lesion, and this is categorized as non-muscle invasive bladder cancer. Another example for non-muscle invasive bladder cancer, this is the GWI image showing that there is a restricted diffusion located for the mass with non-restricted pedicle noted. And this sign in particular is known as inchworm sign. And this is a classic sign for non-muscle invasive bladder cancer. When you look on the T2 weighted image, it is sometimes difficult to discriminate that the lesion is a non-muscle invasive because you can show some disruption in the low signal intensity of the muscle layer. But here comes the role of the diffusion, which confirms the absence of any muscle invasion. Another example for non-muscle invasion is this patient showing T2 weighted image with edema at the muscle layer, and actually T2 can upgrade this lesion as an early muscle invasion. But when we look for the diffusion weighted image, there is an inchworm sign, which is characteristic for non-muscle invasive disease. This is another example where T2 can upstage the tumors for muscle invasion, but again the diffusion downstage these lesions into non-muscle invasion with absent high signal at the base of the mass, separating the mass from the adjacent muscle layer. This is an example for non-muscle invasion, again with the inchworm sign, with the pedicle showing no restriction. As regard the muscle invasion, these tumors have interruption of the enhancement of the mucosa, or we can see that there is extravesical component. This is an example where we can see that the mass is merged with the muscle layer, with muscle restriction seen on the diffusion weighted image, and this is the corresponding ADC. This is an example where we can see a sizable extravesical component on T2 weighted image with the early enhancement of the lesion noted and the disruption of the early enhancement of the mucosa and submucosa, and this confirms the muscle invasive nature of this lesion. And this was correlated with the diffusion with the corresponding ADC map. Let's see some of our cases. This is a patient with this papillary lesion. This is the T2 weighted image. We can see that the muscle layer is completely uninterrupted with dark signal seen all around, with no suspicion that this lesion having any muscle invasive nature. When we look for the early dynamic study, the lesion is early enhancing with persistent enhancement on the delayed image. And on the delayed post-contrast study, we can see that the lesion shows the washout. And here, the diffusion and the ADC, we can see a small pedicle located over here in the diffusion with non-restriction, and it was confirmed on the ADC, and this is known as the inchworm sign, and the final score was VI-RADS 2, and it was confirmed by histopathology to be non-muscle invasive disease. Another example for this patient with this huge bladder mass, and there is disruption of the low signal intensity of the muscle layer on the T2 weighted image, and we can see that there is disruption of the normal mucosal enhancement on the early dynamic study with extravesical enhancement noted, and this is the delayed image showing heterogeneous enhancement of the mass. And this was confirmed on the diffusion and the corresponding ADC, and the final score is VI-RADS 5, and it was pathologically proven to be a muscle invasive disease. This is another example for highly diagnostic features of muscle invasive disease, where we can see a sizable extravesical component showing the same criteria as mentioned earlier, with remarkable restricted diffusion with corresponding low ADC map. So to sum up, vesical imaging reporting and data system was designed and implemented to create a structured reporting system for interpreting multi-parametric MRI for local bladder cancer staging. The combination of T2 and diffusion and DCE is the cornerstone for using this VI-RADS scoring. We can recommend VI-RADS scoring for using the muscle invasive disease because it has a very high sensitivity and specificity compared to histopathological data. My final announcement is that I'm glad to announce the new presence of a new الجمعية المصرية. ده يعني حد صغير من الجمعية المصرية سب سبيشاليتي الإيجيبشن سوسايتي اوف يورينري راديولوجي برئاسة بروفيسور دكتور طارق الضياستي، والاشتراك في الجمعية بيبقى عن طريق أستاذ سامر، ويا ريت كلكم تنضموا معانا للجمعية علشان هتبقى فيها أنشطة علمية كتير إن شاء الله. Thank you.
شكرا دكتور رشا. Thank you so much. I have a question regarding the dynamic contrast enhanced study. I noticed that many cases there is only diffusion and T2 weighted image. Do you recommend to reserve the dynamic to indeterminate VI-RADS on diffusion and T2, or it's must to do it for all cases?
Actually, we are still building our experience in the VI-RADS scoring. So we perform the whole imaging, including T2, diffusion, and the dynamic study. But sometimes the lesions are very classic on T2 and diffusion alone, and no need for contrast injection. But actually, because we can't follow every case during imaging and to decide immediately which patient needs contrast and which patient doesn't need contrast, we do all the whole multiparametric, including contrast injection. Sometimes contrast injection is helpful in discriminating VI-RADS 3 lesions and also in VI-RADS 4 lesions, because the interruption of the mucosa on the enhancement on the dynamic study enhancing mucosa is more sensitive than the diffusion, because we can't discriminate is it extending deeply into the muscle or not. But on the DCE, it is very easy to identify the disruption of the mucosal enhancement.
Thank you.
بشكرك دكتور رشا على البرزنتيشن الجميله. كان نفس السؤال بتاع دكتور طارق بالنسبه للدايناميك ستادي. هي البوينت ان اغلب الناس او نسبه كبيره قوي من اللي بيجوا بيبقى عندهم الكرياتينين عالي، فحكايه الكونتراست بتبقى it's very difficult to do dynamic. ف we can say that we can assess او نعمل الفايراد without the contrast، ولا مش هنقدر نعمل لهم من اصله؟
هو ده لسه اندر انفستيجيشن. يعني هو زي ما البروستات دلوقتي بقت فيه باي بارامتريك وفيه المالتي بارامتريك، بس هو ما زال الفايرادز هو لازم يتعمل الثلاثه ناو يعني في الوقت الحالي. لسه ما فيش ريكومنديشن ان احنا ممكن تأميت الكونتراست من الفايرادز، يعني لسه ما طلعتش الريكومنديشنز دي. بس الحالات اللي هي الستريت فورورد هتبقى باينه من اول الديفيوجن. الكونتراست هيبقى هيلبفul في اللي هم العيانين الايكويفوكال اللي احنا مش قادرين تو سي ان هم دول فايرادز 3 اور 4. خلاص الاكسترا فيزايكال برضو باينين، خلاص دول مش هنبقى محتاجين كونتراست. لكن احنا بنتكلم على الجراي زون اللي هم فايرادز 3 and 4، هم دول اللي فيهم ديبيت هل هم 3 اور 4 اور less. فهو ده الديبيت اللي احنا يعني محتاجين فيه الكونتراست فعلا، فما نقدرش تؤمت الكونتراست دلوقتي. يعني ممكن قدام لما نستابلش بقى يعني الداتا تطلع مور كونسايزد نقدر نقول ان احنا ممكن نعملها without contrast ونخلي الكونتراست recommendation for special category.
بالنسبه للماسل انفيجن احنا في الديفيوجن والتي 2 ويتد ايمج. لو الديفيوجن ستادي proved to ان هو invading the muscle layer of the urinary bladder wall will go with the diffusion in spite of ان التي 2 مش مبينه.
يس الفانكشنال ايميجينج في الفيرادز هي اللي ليها الابر هاند عن المورفولوجيك ايميجينج، يعني الديفيوجن والدي سي اي ليهم الابر هاند كومبيرد للسيجنال كاتيجوري اللي هي التي 2 ويتد ايمجز. فاللي بنشوفه في الديفيوجن والدي سي اي هيجب اللي احنا شايفينه في التي 2.
Thank you very much.
دكتورة صح، دكتورة رشا. طبعا يعني I'm very impressed with your presentation.
Thank you.
English wise, cases whatever يعني كله very nice. Thank you. مبدئيا كده أنا يعني it's known إن هو it's for muscle invasion, okay, which is the point of differentiation as you said at the beginning of the presentation for the type of treatment.
Yes.
Type. We always say that biopsy is the golden standard. Radiology is only a reflection of what we can see of the pathology, but the pathology is directly seeing the cells. Okay, so does this mean that this is supposed to replace or يعني let's say نبعد عن something invasive في diagnosis?
Yes, it can minimize unneeded cystoscopies and biopsies.
Yes.
لو احنا we are confirmed ان احنا ده non-muscle invasive disease هيبقى خلاص diagnostic cystoscopy على طول for removal of the tumor. مش محتاجين ان احنا نعمل cystoscopy twice. Removal, biopsy and then redo ان احنا to complete the resection. خاصة if we have a very huge mass. If we have a huge mass, sometimes they took superficial biopsies without a muscle layer. So they have to do a redo cystoscopy and biopsy. And this prolongs the starting the proper treatment for these patients. Also, it will be helpful in minimizing the second look cystoscopy. After initial treatment of non-muscle invasive bladder cancer, the patient is regularly followed up by cystoscopies and biopsies to monitor if there is any early tumor recurrence present. So this MRI can help to minimize these repeated cystoscopies and biopsies. At the end, it is an invasive procedure, and also it is a costly procedure. And you can't imagine how does it cost in the Demirdash.
Exactly.
It is very costly. I didn't know that it is very costly like this in the Demirdash hospital. So if we can replace some patients to minimize these unnecessary cystoscopies and biopsies, this will be good.
Okay. Which brings me to the other question is, يعني we usually use cross-sectional imaging for staging rather than diagnosis. Okay,
yes.
You use the cystoscopy and biopsy for diagnosis, and then they come back for the cross-sectional imaging for
CT.
the
Actually,
yes,
CT.
Yes. Where is the role of CT in this part? Once you do it, once you you do the MRI and you have diagnosed and that stuff. So you don't need CT?
Yes, the urologists are still resistant for MRI and they recommend the CT for staging and they do the cystoscopy. But we are trying to convince
This is
them.
what I'm saying. So you would
CT,
prefer...
again, CT for nodal staging, it is better, and for abdominal staging, but not for discrimination between muscle invasive and non-muscle invasive bladder cancer. It is for nodal and extravesical staging. Yes.
But I have a comment. Nowadays, it's proved that MRI is far superior over CT in staging of bladder tumor. So it shouldn't be requested CT for the T staging of bladder tumor. So
yes.
Yes, maybe if there is advanced tumor and we look for distant metastasis, may do CT, but for tumor staging, it's only MRI.
So they should start with MRI, and then when they need further back for very distant metastasis, then they do the CT. Okay. سؤال كده بس يعني معلش. What is the relation يعني إنهم بيوصفوا an inchworm appearance. You know what the inchworm is?
اللي هي الدودة عاملة زي
الدودة. طريقة المشي بتاعتها.
إن هي بتبقى curved وفي النص ما فيش.
This is how it appears.
How it looks like in the diffusion weighted image.
It's يعني this is a
classic. Yes, it's a classic appearance for non-muscle invasive
invasion. Exactly. Yes. Okay. Thank you very much. Thank you.
You are welcome.
دلوقتي هنوصل لنهايه السيشن. انا في النهايه بشكر الزملاء السبيكرز دكتورة شريهان مدكور، دكتورة بسنت أبو الهدى، دكتور عصام حافظ، بروفيسور دكتور علياء شيحة، بروفيسور دكتور رشا صلاح.